Hello everyone, myself Dr. Prateek Garg. So today we will discuss about Meniere's disease. What do you mean by Meniere's disease? Meniere's disease, it is also known as endolymphatic hydrop. Endolymphatic hydrop. What do you mean by endolymphatic hydrop? It means there is over collection of the endolymph fluid into the endolymphatic system. So endolymphatic hydrops. It is tough to write with the help of a mouse, but still endolymphatic hydrops. Okay, so Meniere's disease is also known as endolymphatic hydrop, where there is either overproduction of the endolymph or decreased absorption of the endolymph, which leads to accumulation of endolymph into the endolymphatic system, leading to a condition known as endolymphatic hypotension, which will cause the dilatation of scala media. We all know scala media, it consists of endolymph, whereas scala tympani or scala vestibuli, they are having what? Perilymph. So generally Meniere's disease is characterized by three major symptoms or three main systems. Very important for examination point of view, asked multiple times in the exam. So Meniere's disease is characterized by firstly sudden onset vertigo, or we can say giddiness. The next symptom is hearing loss, which is typically fluctuating, plus low frequency sensorineural hearing loss. Remember, Meniere's disease is a disease of inner ear, not a disease of middle ear. So Meniere's disease is characterized by sensorineural hearing loss, particularly low frequency sensorineural hearing loss, which is fluctuating type. Again asked multiple time in the exam. And what is the third symptom? Third symptom is tinnitus, ringing sensation into the ear. So try to remember Meniere's disease, examiner may ask, so exclude the incorrect option from all the four symptoms present in the Meniere's disease. So first one is vertigo, which is spontaneous in attack. Generally vertigo in Meniere's disease will last from few minutes to few hours. We have to differentiate by the BPPV, that is benign paroxysmal positional vertigo. In BPPV, vertigo or giddiness generally happens for few seconds to 2-3 minutes maximum, and there will be then normal, patient will become normal in between, that is BPPV. But in Meniere's disease, generally these attack of vertigo, they may last for 24 hours, and minimum duration is around some minutes to few hours. And thus hearing loss in BPPV, generally no hearing loss, that is a different pathology, but in Meniere's disease there is fluctuating sensorineural hearing loss and tinnitus. Now what is the cause? Either overproduction or malabsorption of the endolymph. If examiner want to ask what is the correct answer, the more correct answer is malabsorption of the endolymph. So whenever there is reduced absorption of the endolymph in the scala media, what will happen? It will accumulate more, leading to endolymphatic hypotension that will lead to gross enlargement of scala media. Let's try to understand by this diagram where we can show the cut section of cochlea. So this is my, in between is my scala media. This upper one is my scala vestibuli, and the lower one is scala tympani. We all know in scala vestibuli and scala tympani, what is the fluid? That is perilymph. PL, I'll write in short form, that is perilymph. Whereas in scala media, the fluid is endolymph. Endolymph. So we all know there is helicotrema in the scala media, stria vascularis, which causes the production of the endolymph, stria vascularis, not helicotrema. So whenever there is malabsorption or overproduction of the endolymph, so what this will do? This scala media will get dilated. So it will bulge like this. So what happens in Meniere's disease? It will bulge. Then it will bulge again, more and more bulging. Okay. So if suppose this is getting more and more bulging, This is my regional membrane, the membrane where I'm underlying. So what will happen? Scalar media will bulge. So this regional membrane will enlarge or bulge to a certain point, at the point of maximum bulging. After that point, what happens? This will burst out. So this will burst out. What happens? Regional membrane will burst out, and this will lead to mixing of endolymph into perilymph. So this mixing will cause sudden hearing loss, which is typically sensory neural hearing loss. So understood how this hearing loss happens? Regional membrane, because of the over-accumulation of endolymph, will bulge and suddenly burst out. So endolymph will get mixed with the perilymph, leading to the symptom hearing loss, which is typically sensory neural hearing loss, and plus it is low frequency. Why low frequency? Because in Meniere disease, the apical portion is affected earlier as compared to basal coil of the cochlea. So Meniere disease, apical coils are affected early. Apical coils are affected early, leading to low frequency hearing loss first, and later on in chronic disease, basal coil is also affected, leading to higher frequency hearing loss. Understood the point? Okay. And the fourth symptom is also present, that is oral fullness. So patient generally has a sensation of fullness into the ear. Now look out at the cochlea diagram. This is just to show. So you all know this is my scalar media, and lower down this is my basilar membrane, okay, and this is my regional membrane. This is my regional membrane. So what happened? This will bulge, more bulge, and suddenly burst out, leading to mixing of endolymph into the perilymph, leading to what? Hearing loss. Now, why vertigo happens? See, the complete endolymphatic system will be affected by this Meniere disease. So this is scalar media present in the cochlea, which is for the hearing. Now what happening? Secule, utricle and secule, they are present in the this inner ear. So what happened to them? I'll tell you. See, this is another diagram which is showing complete membranous labyrinth. So this is my hearing canals lower down, and this is my secule. You can see the red mark structure is my secule, and this is what? Utricle. This is utricle and this is secule. So what happens in Meniere disease? These secule, this is my secule and this is my utricle, they both get enlarged or bulge out because of over collection of the endolymph. And what will happen then? If this secule or utricle will get enlarged, so there will be distortion of the macula, leading to changes in the semicircular canal. This bulging may also dislodge the otolith. So that will lead to sudden attack of vertigo. Understood? So complete endolymphatic system is affected. If the scalar media is affected, there will be hearing changes, hearing loss. And if this utricle and secule will be affected, so what will happen? They will bulge, leading to attack of vertigo by dislodging the otolith or directly putting a pressure over this semicircular canal. So what happens? Endolymphatic hydrop is mostly consistently found in cochlear duct, that is scalar media and secule. And what happens? Going of the regional membrane towards scalar vestibule and distension of secule, we have already studied. When this secular distension is extensive, it can distort the utricle. When this got enlarged, so it will again distort the utricle and the semicircular canal in the vestibule, and this will, or what happens? So this will causes the vertigo, plus this swollen up or bulge out secule, which comes in close proximity to stapes foot plate. We know stapes foot plate is there in the bony labyrinth. Okay, so when this secule will bulge, it will comes in close proximity to the stapes foot plate. So whenever any loud sound hits to the patient ear, what will happen? The foot plate will vibrate, and these vibrations can directly transmit to the secule or utricle, leading to attack of vertigo. So we all know in Meniere disease, loud sound may produce attack of vertigo and hearing loss. That is because of coming up of secule, distended secule in close proximity with the stapes foot plate, and sometimes fibrous adhesions will be formed. I hope you understood the pathophysiology, how the symptoms are produced. Now, Meniere's disease is common in male and female both. Sometimes examiner will ask, the answer may find, females. But females, they are generally more apprehensive, so they will present to the OPD oftenly. If with the minor symptoms also they will come to the OPD, whereas males are more ignorant. If sudden giddiness happens sometimes, so they will ignore the condition until unless it is intolerable for them. So that's why female may present commonly into the OPD, but ideally the male-female ratio for the Meniere's disease is common, and it is generally a unilateral condition. You have to remember, Meniere's disease is a unilateral condition. We know otosclerosis is a bilateral condition. Meniere's disease is unilateral. Examiner may frame out the questions by putting that patient is having unilateral hearing loss, vertigo, etc. So emphasize on the word unilateral. It's because the endolymph malabsorption or production generally happens in one side in initial stages. What are the other predisposing factors? Allergies, sodium or water retention, hypopituitarism or hypothyroidism. Again, it has been asked in the exam. Hypothyroidism and hypopituitarism are the predisposing factors for Meniere's disease. And it has been found that it is associated with cochlear gene. That is CF6 short arm mutation happen on chromosome 6 short arm, that there is a gene present, cochlear gene, will lead to the Meniere's disease. Now, let's discuss how the symptoms are different from other pathology. I told you vertigo, sudden onset vertigo, which will last around 24 hours, less than 24 hours. Whereas in BPPV, the vertigo will attack for few seconds to few minutes. But Meniere's disease, it generally lasts at least for few minutes to few hours. And it will accompanied by the nystagmus, nausea, vomiting, and sometimes some vagal disturbances like the cold, sweating, pallor, or bradycardia. Bradycardia, it has been asked in the last year also examination. So what happens in the vertigo in the Meniere's disease? There happens bradycardia or diarrhea. What about the hearing loss? I told you it is a SNHL loss because Meniere's disease is in a pathology of inner ear, generally low frequency. Why low frequency? Because apical lobes are affected first. Why dysplacusis? What I mean dysplacusis? My one ear is suppose is having Meniere's disease, so hearing impairment will be in the one ear, whereas the opposite ear seems to be normal because it's a unilateral condition. So that's why patient will have different hearing in both the ears. That is known as dysplacusis. And patient will also have intolerance to loud sound, which is known as recruitment phenomenon. So recruitment phenomenon is a pathognomic feature of the Meniere's disease. Why it happened? I told you saccule got distended, comes in close proximity to foot plate. So whenever louder sounds hit the foot plate, directly transmitted to the saccule, leading to attack of vertigo or hearing loss. And then comes tinnitus, which is generally low pitched roaring sound. It is low pitched, low frequency hearing loss, low pitched tinnitus. Okay. Now, there are two pathology. One is the Tumarkin crisis, also known as drop crisis. What happens in Meniere's disease? There are sudden episode of falling down of the patient without loss of consciousness. That means in Meniere's disease attack, patient may fall down, but he will be in complete consciousness. There will be no loss of consciousness. Again, important for the examination point of view, asked in the exam in the last years. So this is known as Tumarkin crisis or drop crisis. Then there is one other phenomenon which is known as Tullio phenomenon, where what happens? Loud sound, they will produce vertigo. I told you, because distended saccule touching the foot plate. So this phenomenon typical of Meniere's disease is known as Tullio phenomenon. Yes. Now, if we do the examination, so I'll look at the otoscopic examination, so it will look out normal because tympanic membrane or the middle ear are normal. So otoscopy will be normal. The nystagmus will be present during the attack. And this first component is towards the normal ear. That means slow component will be towards the disease ear. If we do the tuning fork test, it will show the sensory neural hearing loss. Now, go for the Plato audiometry. So I told you typically low frequency sensory neural hearing loss. How this happen? See, you can see, suppose one ear is affected. This is showing the left ear. So left ear, my low frequency, these are my low frequency, you getting? Low frequency hearing loss is generally started, then there is a flat curve. In chronic disease, high frequency sounds may be affected, but initially the low frequency and sensory hearing loss will be there. So this is a typical audiogram of Meniere's disease. Try to understand why these things are happening. These all are relatable. Now, recruitment test is positive. We have discussed loud sound will appear more louder to the patient because there is dilated saccule and foot plate there comes in close proximity. So patient hearing threshold will be like this, that patient will hear louder sound more louder. So this is a recruitment test typical of Meniere's disease. Then CC, short increment sensitivity index, will be greater than 70%. Again, very important for the examination point of view, CC test will be greater than 70%. What will happen in speech audiometry? See, Meniere's disease is a disease of inner ear, not of retrocochlear lesion. It's a cochlear lesion. So, speech audiometry will be normal. Speech audiometry will be affected in a diseases like acoustic neuroma, where there is retrocochlear lesion. So that is a test to differentiate between cochlear and retrocochlear. So that's how we can differentiate that it is a cochlear or retrocochlear lesion. Now comes the glycerol test. See, we know these glycerol mannitols, these are hygroscopic agent. Whenever there is an hypertension or overaccumulation of any fluid, either in the CSF or in the endolymph. So if we inject or ask the patient to drink the glycerol, what will they do? They will decrease the pressure. So in Meniere's disease, this glycerol test is very helpful. How this is helpful? If we suppose do the glycerol test and ask the patient to swallow the glycerol, so after 10 minutes, if we go for the total audiometry, we will see a hearing improvement of 10 decibel or more than that. So if this test is positive, that means the glycerol test is positive and it is more indicative of Meniere's disease. It has been asked in the exam, so remember these glycerol tests, mannitol tests, generally they are helpful whenever there is a hypertensive situation. So in Meniere's disease, they will lower down the endolymphatic pressure, leading to improvement in symptoms. How we will check for improvement in symptoms? We will do the audiometry and we will see the improvement in hearing. It should be more than 10 decibel in repeated frequency, like 500 hertz, and we do the 1000 hertz. So in with a particular interval. So that's how it's helpful. And then comes caloric test, canal parasite. Now, Meniere's disease, the investigation of choice is electrocochleography. Asked in exam 3 to 4 times. Investigation of choice is electrocochleography, where we can depict the cochlear functions. By the name it suggests electrocochleography. And the diagnostic is summation SP upon AP should be greater than 45% is diagnostic of Meniere's disease. It is an investigation of choice. Some books says that SP upon AP should be greater than 30% is diagnostic. More correct answer is 45%. If examiner doesn't mention the 45%, if it is written that SP upon AP is greater than 30% diagnostic, then also it is correct. Now, what are the variants of the Meniere's disease? Oh, firstly, can we detect the Meniere's disease by CT scan? It should be very precise. Yes, in high resolution CT scan, we can see the bulging of the certain bulging and certain changes, but not very confirmatory. Now, tell me about variants of Meniere's disease. Firstly, the cochlear, where there is only cochlear symptoms are present, no vertigo. So only hearing loss will be there. What is the other? Vestibular hydrop. In the vestibular hydrop, what happens? Only the vertigo is there, no cochlear symptom. Now comes Lermois syndrome. Again asked in the exam in the last year. What is? It is also known as reverse Meniere disease. What is the difference? Difference is tinnitus is the first symptoms that happens, followed by hearing loss or vertigo. So in this, tinnitus followed by hearing loss or vertigo. In Meniere's disease, firstly vertigo or hearing loss happens, then followed by tinnitus. In Lermois syndrome, opposite happens. Now, what is Tumarkin otolith crisis? I told you, sudden drop attack without loss of consciousness. Now, what is secondary Meniere's disease? Secondary Meniere disease, like the congenital syphilis, Paget disease, or post-epidectomy. What do you mean by secondary Meniere's? In this disease also, the recruitment phenomenon is positive, and loud sound may produce vertigo. So it has been asked in the exam. So recruitment test, Tumarkin crisis, that may also happen in syphilis, congenital syphilis, very, very important, asked multiple times in the exam. Paget disease, the post-epidectomy. What is the treatment of Meniere's disease? We all know there is endolymphatic hypertension. So we will advise the patient to have low salt diet. Stop smoking, because nicotine, what will it do? It will do the vasospasm. Then avoid excess intake of water and correct the situations like hypothyroidism or hypopituitarism. Now, what are the drugs that can be helpful? Firstly, the vestibular sedative, because we have to lower down the attack of the vertigo. So we will use the vestibular sedative drugs like dimenhydrinate, promethazine, prochlorperazine. For the acute attack and chronic disease, prochlorperazine. There are certain drugs available in the market with the name of like Stemetil, etc., which will lower down the vertigo effect and also improve certain symptoms of the Meniere's disease. Then comes the vasodilator. We all know chronically beta-histine we use, that is the name of that protein used in doses of 8 mg, 16 mg, 24 mg, etc. It is a vasodilator, which is a histamine agonist. Then comes the nicotinic acid. It has been asked in the exam, nicotinic acid. So there were option given like niacin to confuse you. So what is the correct answer? What is the drug used in the Meniere's disease? That is nicotinic acid, not the nicotine. Nicotine is different. Nicotine is a substance produced in the smoking that will exacerbate the condition, whereas nicotinic acid will lower down or relieve the Meniere's disease symptom. Nicotinic acid. Another carbogen. It has also been carbogen is generally a vasodilator, so it will lower down the system, and we can also use the histamine drop. Other drugs like atropine or diuretics. What will diuretics do? They will increase the outflow of the fluid, so that will decrease the endolymph. Now, if suppose this therapy doesn't help, so we can also intratympanic gentamicin. We all know gentamicin or aminoglycosides, they are vestibular toxic, vestibular cochlear toxic. So gentamicin is particularly vestibular toxic. Tell me the drug which are cochlear toxic in aminoglycoside. So I remember by using the word CAN. CAN is K for kanamycin, amikacin, neomycin. I repeat, kanamycin, amikacin, neomycin. So this CAN, we know CAN, so this is for the cochlear toxic, because we know CAN is for the hearing. So I remember CAN, this short form is for the cochlear toxic, and gentamicin is vestibular toxic. The only side effect is it also produces a hearing loss in longer term. So again, nowadays the intratympanic steroidal trials are also given, which improves the condition in the Meniere's disease, very much helpful. So intratympanic steroid. Now, what are the surgeries that can be used in the Meniere's disease? The first one is conservative procedure. This is very important, asked many times in the exam. Examiner will give 4 options. Out of that, he will ask you to select what is a conservative procedure and what is a destructive procedure. So firstly is the decompression of endolymphatic sac. Now, what do you mean by decompression? I'll tell you. Endolymphatic sac is a membranous system, and any system in the body is covered by the body layer. So what you will do in this decompression surgery, what will do? I will remove this bony part, so that if my bone is removed, so this membranous sac will get a more space to expand. If this gets the space to extend, so that increased pressure will not develop because it may expand. So that will reduce the symptoms of the Meniere's disease. So that's what we mean by decompression, to remove, to open up it from the bony canal. So it is a conservative procedure, decompression. Then what are the other procedure? Endolymphatic shunt, sacculotomy. Tomy always mean to make a hole or to open up. Then Corditech procedure and cochleosacculotomy. These all are conservative procedure. What are the destructive procedure? Labyrinthectomy. Ectomy means to remove. So to remove the labyrinth, that is a destructive procedure. So if you remove the labyrinth, hearing will also be removed. It can be used in very severe intractable diseases where all other modes of treatment is not helpful. So in that we can do labyrinthectomy. And what is the other treatment? Meniere device. What is this device? It will give the intermittent low pressure pulse therapy. So I hope you understood about Meniere's disease. Last one slide. What is superior semicircular canal dehiscence? Also asked in the exam. What is this? Suppose this is my petrous pyramid. And a petrous bone, where above this is the roof of the petrous bone is the middle ear, and below that or into the petrous pyramid there occurs the inner ear. What happened? The semicircular canal, superior semicircular canal bulge. Sometimes this bulge will project from this petrous bone of the temporal bone, and it will come in direct contact with the middle cranial fossa. So what happens? Whenever there is increased pressure into this brain or like middle cranial fossa by means of cuffing, Valsalva maneuver or nasal blowing, these always increase the pressure into the brain. So what will it do? So this pressure will directly transmitted to superior semicircular canal, and that will lead to vertigo. It will produce the conductive hearing loss. Try to remember, in Meniere's disease, SMHL loss was there. In SSCD, that is superior semicircular canal disease, where the superior semicircular canal bulge comes on the floor of the middle cranial fossa, conductive hearing loss will be present, and it is known as third mobile window. Why? Because third window opens up, so any intracranial pressure changes will directly stimulate this superior semicircular canal, leading to vertigo. Okay? And then comes a perilymph fistula. This is abnormal connection between perilymphatic space and the middle ear. Fistula may happen because of the cholecystitis or any bone eroding disease. So there will be a connection between perilymph space and middle ear. So again, in this condition, any valsalva, coughing, straining to put the pressure will increase the vertigo attack, because the pressure changes will get directly transmitted to this perilymphatic space, causing the vertigo. In this, fistula test will be positive. So I hope you got it. Thank you.